Hi, and welcome to our Path to Parenthood seminar series brought to you by the Fertility Hub. I'm Veronica Montgomery, and I'm the Patient and Clinic Liaison Consultant here. The Fertility Hub is an online platform that brings couples who are trying to conceive together with healthcare providers to achieve a pregnancy. My background has been working with couples who are struggling to conceive for the last 15 years with an IVF unit and the last 2 years with the Fertility Hub. Every fertility journey starts with ovulation. So I'm really pleased to be joined today for the seminar by two experts in the field of both fertility and more specifically ovulation. So welcome to Rob Milnes and Kate Davies. Both of our guests today are from Fertility Focus, who produce the OvuSense Ovulation Monitor. So if we start with you, Rob, could you just introduce yourself and tell us a bit about your background?
Sure, I've been in medtech for 30 years now, so I've been in bringing medical devices to market, dealing both with doctors and directly with consumers of the devices. And I've been in women's health for the last 15 years. So I ran a fetal monitoring company before this and then joined Fertility Focus around 10 years ago to bring the OvuSense product to market.
Great, thank you. And then we've also got Kate with us as well. And moving on to you, Kate, you're a nurse specialist. So could you tell us a bit about yourself and your fertility background, please?
Yeah, certainly. So I'm a fertility nurse consultant. I'm an independent fertility nurse consultant, and I have my own practice called Your Fertility Journey. And I've worked in the field of women's health and fertility for over 20 years now, probably getting more on 25 years, which makes me feel very old. And I first came across OvuSense and Fertility Focus about 7 or 8 years ago now, Rob. And I thought this is great because this is all that I'm doing, everything that I'm doing with my patients, but I just love the fact that it was so convenient and much more effective. So that's when Rob and I kind of got together, and I've been working kind of independently, but alongside Fertility Focus for the last 7 or 8 years.
Lovely, thank you very much. All right, so today we're going to specifically look at ovulation and most importantly, ovulation monitoring and how this data can help patients' healthcare providers to treat them more effectively when their cycle isn't regular. So I'll hand over to you two now to do the presentation and give us some facts on the trying to conceive journey. For anybody watching, if you have any questions, please use the chat feature. There is a chat box on this YouTube premiere, and or you can write your comments in the comments section below. When we finish the presentation, the chat feature does close down. But again, if you put them in the comments afterwards, then they do get emailed straight through to us, so I'm alerted that you've asked the question. And obviously we'll give you contact details at the end as well for anything specifically you'd like to have a private conversation about. So I'll hand over to you two now, and if you don't mind, I'll just interject with any questions I've got as we go along.
Please do, yeah. So thanks very much, Veronica. It's important, I think, that we discuss the whole background to the issue why ovulation is relevant and why measuring it is relevant. So in fact, what we've done is we've decided with you to break this into 2 parts. We have some very new clinical research that we've released that we'd like to discuss in part 2. The reason for that is it's really important to set it up with an understanding of the background to ovulation, as I said, and the market for ovulation monitoring, which is really talking about the consumers of those devices. So the topic is very much around the fact that 70% of women struggle to conceive, and they do so because they have some issue with what we call subfertility, i.e. something that is causing them not to be able to conceive that happens before they're deemed to be infertile. That's usually at 12 months, as you know. And we have 2 offerings in this market. The first is the OvuSense product, which predicts ovulation up to 24 hours in advance. It confirms the date of ovulation, and it helps women to monitor the rise and fall of temperature over each cycle. And temperature is very useful for understanding what's happening with progesterone, and we'll go on to talk about that a little bit more later. And then the second half of this presentation, which we won't discuss today, but we'll do in a second part, is about our new Ovisense Pro product, and that's very much more aimed at the clinician and helping them to understand better what's going on within each cycle, and then monitor the effect of any treatments that they decide upon, and really, obviously, under the current circumstances with COVID-19, it's particularly important because it helps people monitor remotely. This whole presentation is based on some presentations we have already given this year to clinical practitioners, and that's really important because Ovisense is a little bit different than any other device out there. We are a Class 2A medical device, and that means we have to make a regulatory submission that is updated every year. Our regulations that govern the Ovisense product are much more stringent than those that govern other products within the market. The good news about that is we have to author clinical research ourselves, and we also have to involve independent clinicians in that. So what I'm presenting is essentially based upon that background knowledge that we have to have about the product and the market in order to bring things to market. So let's go on to talk about the problem. In essence, we know that there are around 12 million women each year that enter into the market of what we call trying to conceive. So the TTC population is around 12 million new people each year. And of course, that's moving all the time. Whenever somebody goes and starts trying to conceive, they're generally new into that market, but people are still trying to conceive, obviously, throughout a period of time. And we normally break this down into sort of three groups. So there's about half of that population in North America and Europe are trying to conceive within 0 to 6 months and largely will conceive within that time. And we've based an entire healthcare system really around those people that are lucky enough to conceive quickly. We also have an increasing number of women that struggle to conceive, and that's anything beyond 6 months of trying to conceive is included in that. And then also, obviously, people tend to go on into clinical treatment, and we've largely put the mark on 12 months here, but it can take some people 2-3 years to get into treatment, particularly under the NHS, whereas some people may go privately, obviously, and they'll do that straight away almost. So why is this an important thing? Essentially, the background to this market and the reason that those segments at the end of the market are growing so fast is that we're trying to conceive later and later in life. And we'll talk about what that means in practice on the next slide. But in essence, if you look at, the source for this is Eurostat, the average pregnancy age in 1980 was below 27 throughout the European Union. The average age is now over 30 in almost all countries, and in some countries it's considerably higher than that. So in Germany, for instance, it's pushing 32, 33. We're still at around the 31 mark as an average age within the UK. So the impact of that back in 1980 wasn't particularly great. If we ask women to wait for a year or 2 years, as is sometimes the case now, before they come back and get any form of diagnosis and treatment, that was fine in 1980 because at that time, only around 25% of the population would have had a problem with infertility. So 3/4 of the population were going to get pregnant. Doesn't matter how long you waited. Essentially, if you were going to wait 1 or 2 years, it was fine. Now we're at the age of 31, the average age of 31. The chances of you being able to conceive have gone down considerably in that period of time. So the chances of you, in other words, having a subfertility problem or an infertility problem is much greater. And as you know, we now wait, we make people sometimes wait 6 months, even if they're over the age of 35. And that's a really, really difficult place. As we say, we're at the cliff edge there in terms of the population. I don't know if you want to comment on your experience of that, Kate, in your practice.
Yeah, I mean, I think I've noticed markedly in the last 2 or 3 years that I'm seeing women definitely trying to conceive until later on in their 30s and even in their early 40s. And in fact, it's so marked the difference that my conversations have completely changed. Perhaps 5 years ago, if I saw a woman in her early 40s, I'd be having a very different conversation then to what I'm having with her now. And we know that the latest statistics as well from, I think it was 2017 or 18 statistics from the HFEA showed that we're seeing more pregnancies in women in their 40s. That level has gone right up than we ever have before. Or we're seeing a lot more women who are going through fertility treatments as well in that period than we've ever seen before. And luckily, teenage pregnancy rate has dropped right down. So there's a benefit there for sure. But yes, that's exactly what I'm seeing, is that women are leaving it till later, and therefore we're having these issues now because we're not able to move any further forward with referring them onward any earlier than we currently can.
I mean, if I could just add something there, you know, the messages that we get sent to the Fertility Hub and, you know, patients I've spoke to over the last few years are just trying for too long. Mm-hmm. You know, they are trying for years and not seeking any medical advice. And, you know, my first question is always, you know, are you monitoring your ovulation? And it's very, very often no. So, you know, not only are they older and they sort of make the decision to try for a child, but they haven't sought any help whatsoever. You know, so sort of something I'd want to put across to people watching is that, you know, as soon as you make the decision, one of the first things you need to do is, first of all, you know, just instead of trying month after month and going through that disappointment, is start your ovulation monitoring, you know, from the minute you decide. Because, you know, depending on your age, it's the sooner we can identify a problem, the better.
I think there's still a reluctance among many clinicians to recommend fertility charting. And the reason that reluctance is there very historically is it's often felt that monitoring your fertility is actually going to contribute to your stress and your anxiety. But actually, I find that it's very different from that. I find the majority of women tell me they feel so empowered by having this information. They feel that they have taken back control of their fertility, where perhaps they'd somehow lost control of that, or they didn't have that knowledge and awareness. And so actually, I think we need to change that narrative now, because that has very much changed, and that women are demanding this type of information. They do need this type of information. I think we're still scratching the surface about getting education and fertility awareness out there, but the women that do decide to take ownership for their own fertility and start to use a method for tracking their ovulation find it incredibly empowering. And we know that time to conception is significantly reduced with fertility awareness knowledge. So it makes absolute sense to do it.
Yeah. Good.
Okay, thanks for that. It leads on really nicely to this next slide, which is when we started out on the mission of bringing the Ovisense product to market, what we understood to be the problem partly was expectant management says, don't worry, you'll be all right because most of you are going to be all right. Go away and keep trying. And in actual fact, what we know from, again, this is from a considerable piece of work that was done around the literature of telling us why women struggle to conceive. We know that most women, when they have an issue that causes them to fail to conceive, they have that issue when they start out. And the question we're asking as a result of that is, why wouldn't you, if you had a method of screening for those issues, why wouldn't you try and do that sooner? And our Ovisense Pro product speaks to that particular issue. And as I said, we'll go on and talk about that at a later date. But what we've done here in this particular slide is map the types of reasons why you may struggle to conceive as a woman. So we've taken male factor infertility out of this picture and then said, what happens to that population as it tails off? And what you see very quickly is that the number of people who are likely to be fertile, i.e. conceive within that first 12 months, is rapidly diminished by the time you get to month 6 or 7. So if you've been trying for 6 months already, the chances are, your chances are much higher that it's going to take you much longer. And that's one of the things, that's why it's so important, Veronica, as you were saying, that you don't leave that monitoring process too long. You don't wait too long to find out things. So the other reason why we have this kind of expectant management approach is really the myth that women all ovulate in the same way and at the same time each month. And it's still amazing to me that we continue to talk about the fact that women are meant to have a 28-day cycle and a day 14 ovulation, because it's quite clear from the literature, and we've spoken about some literature right up front in this presentation, but our own literature, this is a publication just this year from 15,000 cycles of Ovisense users. When you bring, so what we've done here is we've normalized the day of ovulation in a 28-day cycle, independent of how long their cycles actually were, and we did that on a percentage basis. So what this shows is that, in fact, very few of the users of the Ovisense product ovulate in what you would consider to be the middle of the month, i.e. day 14 in a 28-day month. The vast majority of them have what we call later, or in fact late ovulation, so day 18, 19, 20 onwards in the cycle. There's a very large number of our users have that, and it's reasonable to assume that the background population has this same thing. So not only do we say go away and keep trying for a year, but we give couples actually a false understanding of when it's likely that they're going to conceive in their cycle. Yeah. And that's why, as Kate said, we know, again from the literature now, that if you educate yourself about your cycle through the signs such as cervical mucus and temperature charting in particular, you have a much higher chance of conceiving, simply because you're probably trying to conceive at the wrong time in the month.
Yeah.
And we'll see that time and again.
I look at charts day in, day out, and I can honestly say to see an ovulation on day 14 is actually quite unusual, yet that is what we're perpetuating. And so I think it's absolutely fascinating to see this actually in a bar chart, because yeah, that's exactly what we see. And I think my biggest bugbear is women are often told, go away, keep trying. They're not given any information or advice on how to optimize their fertility in every single way. They're not given the information that we've just talked about the importance of monitoring your temperature and your cervical mucus. So like you say, Rob, they go away, carry on trying to conceive, but without that empowering information, you're just going to unfortunately continue to struggle. And it's so important to take it into your own hands.
And I'm sure you're going to come on to it, Rob, but obviously maternal age, does play a huge part. I mean, you sort of covered it in the beginning of what how much younger women were in the 80s trying to conceive, and now we're looking at an average age, above 30. But I think it's always sort of just important to remind people that, if you're under 35, the sort of industry standard is, you must seek medical intervention after 12 months if no conception has taken place. And after 35, that halves to only 6 months. So if you're over 35 and you haven't conceived naturally within 6 months, then you must, find out there's an underlying, or as Rob says, a subfertility issue going on there.
Yes, and I mean, again, leads nicely onto what we're going to talk about now. So there are a range of tests out there, diagnoses of particular ovulatory problems, and subfertility issues are largely due to ovulatory problems, although tubal factor is not part of that, and endometriosis is not part of that. And we generally don't offer these up front. So you have to either pay privately for them, or you have to wait your time, as it were. What we've done with the Ovisense product is we've learnt about women's cycles. So you saw that publication was into 15,000 cycles. We're now at over 145,000 cycles that we have taken of women's temperature charts over time. So we're just going to talk a little bit about the Ovisense product and what it does and how it's doing that. So what we're measuring with Ovisense is continuous core body temperature. And again, literature tells us that that is a much more accurate reflection of the action of progesterone on the ovaries than temperature charting using an oral temperature or using skin temperature. What it gives us, more importantly, I think, is a chart over time. And it's not actually just the curve that's associated with ovulation. So temperature should rise during ovulation, and it does so in a very predictable way for almost all women. But it actually tells us what's happening to progesterone at different points in the cycle as well. So in general, you expect temperature to start out low, and that's a reflection of progesterone starting out low at the beginning of a cycle, and it then rises usually about 0.3 or 0.4 of a degree Celsius during the process of ovulation, and it should then stay high. If you see anything other than that pattern, the chances are there's some form of ovulatory issue. And as I said, that our research has now gone into what those patterns mean, and that's what we'll present in the second part.
Sorry, Rob, could you just sort of explain how the Ovisense monitor works?
Sure, yeah. So it's using a vaginal sensor, which is placed in overnight. It takes readings of core body temperature every 5 minutes. And you take it out in the morning, this sensor, and download data to the Ovisense app. So the Ovisense app is free, and you pay for the sensor and a subscription to download your data. And you're basically downloading a continuous night of recordings from which we calculate the most representative temperature for that night, and that's the thing that's plotted on the chart. You can see two different temperature charts on Ovisense. The first is what we call the raw temperature. So that's the representative temperature for each night. That tends to bounce around a little bit, particularly if you have something like PCOS, polycystic ovarian syndrome. And then we have what we call a smooth curve, and it's the smooth curve that Ovisense uses to calculate when ovulation is going to occur. So we predict it in advance, up to 24 hours in advance, and we then confirm the date of ovulation. And that's all using the current cycle data. So that's really what's different between Ovisense and other devices. We're using the current cycle data to see what's happening. That's particularly important if you've got any variability in the length of cycle or in the timing of the ovulation.
I think it's also important to say as well that unlike basal body temperature recording, that can have disturbances such as the temperature in the room, core body temperature is a much more effective way of monitoring temperature generally, but particularly for fertility, because it's your core body temperature, the temperature that your body is keeping all your organs at. So it's a very, very accurate determination. So you'd get the sensitivity and the data is a lot better with core body temperature than it would be with basal body temperature.
So it's a really silly question, but I'm sure it's one of what a lot of women would like to ask.
No silly questions.
What size is that sensor?
It's actually no bigger than a tampon. I think it's difficult to see, isn't it? But it's actually no bigger than a tampon, really. It's really easy to insert. It's really comfortable. Just like if you insert a tampon correctly, you shouldn't feel it. And that's exactly the same with Ovisense. As long as it's inserted correctly and actually pretty much as high as you can get it.
How big this is? That looks big.
No, literally, it really isn't. It isn't. And I think in my experience, most women at first are like, what, you want me to put that where? But then when they start using it, they're like, this is so easy, so incredibly easy to do. And often I have women say to me, I love it. I absolutely love it, which is great. So I think I could honestly say I've very few women have experienced any problems with inserting it or using it.
That looks large. I must ask about that. Okay, great, thank you.
Yeah, I mean, I think it's important to understand just how many women have succeeded in using it as well. We've had over 25,000 women now use the Ovisense device. It's been on the market since 2013. There's been over 145,000 cycles of recorded data with it. You know, it's really very much tried and tested. And what we found in general is that women that choose to use it have already made up their mind that they're not going to have a problem with a vaginal sensor. So I'm certain there's a range of people out there who will simply say, that's not for me. But the people that do start with it stick with it because they don't find it to be a problem once they've started with it.
Yeah. I think that, and again, that's just sort of getting over, like say, it's just sort of a mental decision as to whether that's something you want to do every night. But on the other hand, you know, if it's going to give you the data that you need in order to conceive, then it's a small price to pay. You know, just to sort of, and as you say, if it's not uncomfortable, if it's just like a tampon, then that's okay. All right, we'll let you carry on, Rob. That was just my interjection there.
No, that's a very good question, very important point to make as well. And much easier made by Kate than by me. The one thing we discussed and touched on there, which is important to talk about a little bit, I think, is why is there this association between temperature and progesterone? And in essence, the cycle that you see, the level that you see of temperature is showing you the level of progesterone. So that's the starting point. The reason why temperature rises is because progesterone is thermogenic. So when it's released into the body, it creates a temperature rise that's a thermogenic, what's known as a thermogenic reaction. And that's the thing that we're measuring. And the original research we did for the product back in 2012 showed us that all women, regardless of whether they had ovulatory disorders or not, have the same type of curve of temperature. So this 0.3, 0.4 of a degree rise that we're looking for over a 2 to 3 day period, that is what we saw happen for women with PCOS and women with completely normal cycles and no ovulatory disorder. And added to which we then looked, you know, then if you go back in time in the literature, that is confirmed by all of the other literature associated with temperature monitoring and cycles. So that's really good news, is we were confirming back what had already been seen, but using much more accurate methodology of finding that temperature in the first place. So that leads us on to perhaps the last point that we need to talk about today, which is what are all the various different methodologies out there? And we won't go into great detail about this, but most people know about urine testing strips. That's a good place to start. So the two main brands out there are Clear Blue and a company called First Response. And then if you go into Boots, Boots have their own brand and so on. And these are generally strips that are a lateral flow test, which are being talked about a lot at the moment, but this is in this case, it's a lateral flow for urine. So you pee on the stick and it gives you either, depending on how sophisticated it is, a little blue line, or it gives you a smiley face. And that means that you have got a peak of what's known as luteinizing hormone, which is the hormone which in normal cycles for women without ovulatory problems peaks very sharply 24 to 48 hours before ovulation occurs. So those are very, very good devices for women with regular cycles that understand when their ovulation is likely to occur, and they can use 2 or 3, and usually we'd say if you get 2 positives, that's a good sign that you're going to get an LH surge and you will ovulate within the next 48 hours. The problem is that they don't work well for women with ovulatory issues. So if you're struggling to conceive and you don't know why, the chances are you may be one of the people for whom these tests don't work. And the issue there is simply that a woman with an ovulatory issue tends not to have that spike of LH 48 hours before they ovulate. They can have it at any point or not at all within their cycle. Most commonly with PCOS, you get a very early spike and then you get a sort of flat line and you'll get what are essentially false negatives. And that's why the positive predictive value, which is telling us how many times does it get it right when it tells you you're going to have ovulation, the positive predictive value is 92% for those strips. So we then move on to, so those are the only devices out there other than Ovisense which predict the onset of ovulation in this cycle with this cycle's data. That's a really important point. The other types of devices out there largely are confirming that ovulation took place in this current cycle. So we include amongst those fertility apps that are generally free, where you type in when you think you ovulated and when your period was. And they generally use that information on an ongoing basis to say, well, you appear to have regular periods, so I'm going to say when your ovulation is likely to take place. But in fact, the literature says they have an accuracy of around 21%. So very, very low accuracy. Only 1 in 5 times is it telling you something that's useful and correct.
And I just want to add to that, Rob, because I see so many ladies that use these apps believing that it's giving them correct information. But it, as Rob said, it's so clear that basically it's like just like using a calendar or your diary. It's if you're not putting any physiological data, i.e. your temperature or your cervical secretions, into that app, then that app is just no better than your diary. And in fact, it can actually be worse because it's misleading you by putting in just your last menstrual period date. It's then using a calendar method to work out when it thinks that you're ovulating. And if we go back to the whole day 14 thing, that's the information it will be giving you. But as we've demonstrated, very few women will actually ovulate on day 14. And therefore, if they're relying on these calendar-based apps, then they could actually be missing ovulation altogether, which I think is heartbreaking. And I see so many women that are relying on these. I think that's so important that we educate women about this and that they move away from those apps. They can be very useful for, you know, knowing when your period's coming, but really it doesn't give you any more information than that.
Yeah, and I mean, you know, if you've got some, which we'll talk about in the next presentation, but you know, if you've got somebody who's got like a 52-day cycle, then using a fertility app just isn't catering for that at all.
That's absolutely right.
Yeah. Okay. Good.
So moving on to the other temperature methods. So basically we talked about these already. Oral temperature, which is where you stick a thermometer in your mouth once every morning. So you're meant to do it as you wake up because that's meant to be the best representative of what's known as basal body temperature, the lowest temperature that's the closest you can get to the lowest temperature that's taken overnight. Issue there is variability in terms of when you take the actual measurement itself, and probably more importantly, the resolution, so the amount of steps that you get in temperature monitoring in an oral thermometer is only 0.1 of a degree. So we're looking for 0.3 of a degree rise to tell you that ovulation has occurred, and you're using a device that might be out by up to 0.1 of a degree. You can see that fairly quickly that if you have, particularly if you have a temperature that varies massively, which women with problems trying to conceive tend to, then you're going to get inaccurate information in terms of telling you when you ovulated. So accuracy is around 83%. I should say that we've got the sources at the bottom of this. These are all based on clinical studies that have been published.
It's also convenience as well, isn't it, Rob? Because actually using basal body temperature, although it can give you some information, it's not as convenient. You know, you have to think about taking your temperature first thing in the morning before you sit up, before you talk, before you have a cup of tea. And if perhaps you're trying for a second or third child, that can be then difficult if you're having to get up to go to your child early in the morning, or you're perhaps having a disturbed night's sleep, and therefore you're not going to get the accuracy in your temperature recording. So the convenience, I think, plays quite a big part into that as well.
Mm-hmm. And then there's skin-worn temperature devices. So several of these have been launched in the last few years, and they're about the same level of accuracy. The only difference really that you've got there is that you're measuring a number of data points overnight. So you might be getting a slightly better estimate of the overnight temperature. However, it's not within a body orifice, so the chances of it being close to your actual core temperature are very low. So around about the same accuracy. Both of those methodologies, very important to understand this, they can predict for you when you're going to ovulate in the next cycle, but they do so exactly the same as we said before, on the basis that you have regular ovulation and or length of cycle. If your ovulation, if you have the same length of cycle every month, so let's say 30 days for the sake of an example, and you ovulate, say, on day 13 one cycle and 17 the next, these devices can't help you. And that's not uncommon, as we've said. We've found people that very commonly have that kind of problem. So that's the worst case scenario, because people who have regular cycles, i.e. same length each month, probably think that they've got regular ovulation as well. That's not always the case. Then if you've got irregular cycles, the chances are that your ovulation actually follows in a more of a percentage fashion when it occurs each day within each cycle. But even that is very variable, and obviously it depends on the variability. So neither of those methodologies can be used to predict in advance. So just rounding off, if you go to your GP and you're lucky enough to get a test, you're likely to have a progesterone blood test. And that is a very accurate test, but it's very, very dependent on the day that the blood is drawn. And if it isn't 7 days after you ovulate, you may get a false negative. Generally, it's a false negative. So something telling you and your GP that you haven't ovulated when in fact you might have done. Many of our users have used OvuSense to tell their GP when they think they should have their progesterone test, and the progesterone test is then very valuable to them in confirming with another methodology that ovulation took place. And then lastly, ultrasound is kind of the gold standard, but your chances of getting ultrasound scans at a GP surgery are, very close to zero. You can usually visit a specialist clinic for those, and it's a very accurate method, but only really if you take more than one scan in a cycle. And again, it's very important you know when you're likely to ovulate in order to have that test carried out. So that's really all we had to say in the first part of this discussion.
No, I think that's really useful, and it's worth just sort of reiterating to any couple who've made the decision to start a family that, you always need just one viable sperm and one viable egg, but that egg is only available in one 24-hour window a month, sort of going back to basics. But some couples miss that point completely of just, they think that you can get pregnant anytime, and as we said about, teenage pregnancies have gone down. It is incredibly difficult to get pregnant, and there really is, it's all about baking that cake, really, of getting the egg and the sperm together at the right time. And we just sort of can't reiterate enough that you need to know when you're ovulating, because it's just not something that we can see. And even if you do think you know your body quite well and your cycle quite well, without physical evidence, you using apps, etc., really won't tell you. It's just the guessing game. So we're going to organise a second part, which will look at the actual research behind the data that we've presented, some of which today, and the rest of it will come in the next one. Kate, I just sort of wanted to finish off with you, really, because obviously you're the nurse, you're the one who's medically trained to speak to patients, whereas Rob and I speak to them and look at their data, but we're not actually qualified to do that, or not to give any medical advice. So I'd just like to sort of hear from you. Obviously, as you said, you've been working with OvuSense for the last sort of 6-7 years. There's always some great stories, and I like to sort of end on a high of motivating patients that, people you spoke to have been very frustrated and then found out it was something so simple. So I just sort of want to end the seminar on giving these couples a bit of hope that, we can turn this journey around. It's just knowing what to do, and knowledge is power.
Yeah, I mean, absolutely, knowledge is power. And I think if I had a penny for every woman that said to me, gosh, I didn't know that. I really didn't know that. And then when they have that information, that it is like this light bulb moment, and it's the type of things that we should be told in school, and we're not. Why do we have to wait until you're struggling to conceive to learn all of this information? But I've seen so many women that have completely changed the way that they are, I guess, trying to conceive. They start to do so many different things, not only charting and thinking about their cycles, but their lifestyle and how those things can come when they come together. Because I'm a firm believer that it's never just one thing, it's everything. You have to get everything working right. The egg has to be right, the sperm has to be right, your timing has to be right, your supplements, your lifestyle, all of those things have to be working in perfect harmony. But this knowing about fertility awareness and having that empowerment can make such a difference. And I really, well, my last thing I guess to say is I really want more women to be doing it, because it's something that we just see the difference every single day. And certainly with Ovisense, as well as having that ability to understand more about your cycle and understand perhaps where things might not be quite right, so you can take that information to your doctor, is just incredible. And you can really then make steps in the right direction. Otherwise you're kind of going about it all a bit blind, really.
Presentation, we're going to look at signs of underlying fertility issues that the sensor can tell us. But yeah, so we'll save that for the next one. All right, well, we shall keep tuned to the Fertility Hub, because we'll be announcing when the next one will be. I would say probably now that's going to be some stage in December that we'll run the next one. But yeah, it'll be put up on the news section and you'll be able to register. Thank you so much, Rob. Thank you so much,
Thank
Kate.
you.
I hope everybody enjoyed that. As I say, if you have any questions, you can email email me, Veronica, at thefertilityhub.com. You can use the contact us feature. And is it contact@ovisense.com for you guys?
Support@ovisense.com is the best one.
Support@ovisense.com.
Yeah.
And as I say, when you're watching this, if you just have any questions as we go along, type them in the chat feature, or you can leave comments afterwards, because this will stay up on YouTube after we broadcast it. So thank you both very much.
Also.
Thanks, Veronica.